We welcome you for this monthly meeting. This is going to be from the Department of Dermatology. I personally see, this is not, the title which is very closely associated with dermatology. It's a topic of every specialty, So adverse drug reactions not only involves the cutaneous region, it can also involve the internal organs. See, for example, the dress can involve the mucous system, can involve the lungs, heart, kidneys and liver and so on. So we see a lot of drug reactions daily, it can be macule, bacule, it can be purpurary crash, it can be erythroderma, it can be lichen reactions, it can be TEN, it can be Steven Johnson, you see, it can be erythroderma, it can be exclusively, for example, nurses are there, they see exclusively, they sometimes, most of the time you see infusion related reactions, it can be type 1 reaction, type 2 reactions and so much. For a clinician, I think the dreaded problems of type 2, the unpredictable idiosyncratic reactions, like which involve, the deeper part of skin as well as mucous system, like the Steven Johnson and the dress and so on. The point I want to emphasize here for the students are also here, it's not the higher dose that can lead to the drug reactions. For example, you give normal dose for a patient who has organ dysfunction. For example, if you give a paracetamol dose, normal dose for a patient who has a liver cell failure, can be toxic. On the contrary, a single drug, even a single drug can produce the problems. For example, if we give an aspirin for a single dose of aspirin, can lead to sometimes the giddiness. If you give the lethal dose of aspirin, it can produce the other end of the drug reactions, commonly the acidosis, metabolic acidosis. So sometimes you introduce a drug, same drug, sometimes you don't introduce the same drug. For example, if you have the cotrimoxazole-induced hypersensitization, if you don't have other alternatives, you can always use the same drug to re-challenge like you do for aspirin. But certain drugs, drug reactions, you cannot introduce forever in medicine. For example, rifampicin. You see, if you have a rifampicin-induced acute nephritis, it's an absolute contraindication to use the same drug again, as like in other group of drugs. There are various classes of drugs which can produce various kinds of manifestations. None of the drug is safe. That is what the pharmacological principles are. Even there are patients who develop reactions to vitamins. There are patients who develop anaphylaxis for vitamins, immune-mediated reactions. There are patients who develop anaphylaxis or erythroderma kind of reaction for steroids. We had a patient yesterday who had drug reaction to steroids. And that is where the stocking epinephrine becomes hold in hospital emergencies. So it itself is a big area and very interesting. The title as far as the dermatology is concerned. As a student, our dermatology professors used to ask, just go and read. So remember our days of referring the IADV textbook 1 and textbook 2. I think the 2 volumes are there in IADV. So there are interesting reactions are given. If you read, as a student, I used to think, if you read all those, none of the drug will be safe at the end of the day. But that's not the case.
The management is mainly the withdrawal of the drug, and we have to give an emollient. Sometimes, mostly in maculopapular rash, if it is very limited reaction, if it is earlier if the patient is visiting a doctor, we just need a topical steroid and withdrawal of drug. We've had symptomatic treatments like emollients and antihistamines. If it is very severe, and if there is any mild any other involvement, and we can start on systemic steroids as well. And this resolution is very faster. Like infectious symptoms, if you are not stopping the drug, that's how we are differentiating between the both. Because drug-induced symptoms, if you are stopping the drug, the next day we can see the improvement. This type of the drug-induced maculopapular rash. Okay. So next topic is drug-induced pruritus. Sometimes a patient will come to us with saying the pruritus. At this point, it is very important. We have to take the drug history. So, in what all medications are there? For elderly patients, most of the elderly patients will have the very common symptoms like pruritus. So, the total history is very important. That is whether the patient is on, because senile pruritus is also a very common condition. That is the pruritus in old age. So these people, the elderly people, will be there in multiple drugs, and it is very important we have to take a proper drug history and the temporal relationship of this pruritus. If the patient is saying my pruritus has started from this point, and we can, if it is from a long period, that is a very important thing we have to ask a patient. So from when the patient started pruritus and what is the onset, when the drug has started. So any drug can cause this pruritus, like because the mechanism behind this pruritus is different. It can be due to the direct involvement that drugs can produce direct immunological reactions in the skin, and it can generate multiple pruritogens in our body, and this can be related to the systemic involvement by like renal involvement, liver involvement, which leads to pruritus or even dryness. This can cause pruritus. So multiple mechanisms are there for drug-induced pruritus. It is not only hypersensitivity reactions or any other immunological reactions. So multiple mechanisms are there. So multiple mechanisms leading to multiple organ involvement leading to pruritus, also a common thing which can be seen in drug-induced pruritus. So here, with there is no clinical examination can know how this will present, or only with the history we can know this drug-induced pruritus. So even some application of topical agents, like any topical agents we are applying, even in the dermatologic part of view, if you are applying anything, it can lead. Even the corticosteroids application itself the vehicle in that even can cause the pruritus. So like calcineurin inhibitors and beta blockers. So, most common drug-associated pruritus is due to opioids. Opioids, we can see many people complaining like having an itching after taking these opioids. So, only way we can, we have to stop the medication, we have to replace this with some other medications. So, some of the opioids we also give for liver and renal involvement or renal pruritus or liver-induced disease, chronic liver failure pruritus. So, some opioids like naltrexone we can give in that also. So, for that kind of drug reaction which is caused by opioids, we can replace with this naltrexone also. And the statin which will reduce the content of cholesterol content in our skin. That is a mechanism in which statin is inducing pruritus. And paclitaxel, antimalarials. Antimalarials has a very complex reactions which leads to pruritus. It releases a lot of pruritogens. It leads to immunological reactions in the skin which leads to pruritus. And then granulocyte macrophage, most drugs associated with doesn't mean that these are the only drugs. These are the very most common drugs. I just gave very few examples which leads to these conditions. And interleukin 2s, many biologicals and ACE inhibitors, this sulfonylurea derivatives, NSAIDs and SSRIs. So the cessation of the culprit drug brings rapid relief, and mostly the most kind of pruritus, these antihistamines are not going to work. The only thing it will work is like topical menthol or any capsaicin or something which soothes the skin, the moisturizers, because the pathomechanisms behind the pruritus is not histamine. That is the reason the antihistamines are not working in pruritus due to drug reaction. So sometimes we need opiates for this type of drug reaction, or even stoppage of drug itself. Next, within a few days, we have a rapid relief from this kind of drug reaction. So for opiate-induced pruritus, as I said, we can replace this opiates with, in this condition, sometimes like lowering the dose of opiates can give the relief from the symptoms. And the naltrexone, naltrexone, gabapentin, these can be used for opiate-induced pruritus or severe pruritus due to drug reaction. Even after stopping the drug, if there is no much difference, we can give this type of medications, because antihistamines have very less role in pruritus due to drugs. And in resistant cases, sometimes we need phototherapy. Second thing is drug-induced eczema. So drug eczema means there has many stages like acute, chronic stages. Eczema is a condition where it is also an immunological reaction. What will happen is there will be an acute stage of oozing, dry skin, and the chronic stage of lichenification, that is thickening of the skin, or hyperkeratotic skin. That are the stages of eczema. So sometimes what happens is in eczema, when maybe the patient already have a kind of eczema like atopic dermatitis or any kind of eczema, steatotic eczema, and due to dry skin. So many type of eczemas will be there that can be exacerbated due to drugs. So it will be very much troubling for the patient that the existing eczema itself is a very troubling thing, that is, it has a lot of itching will be there. The patient will have a lot of trouble due to this eczema. This can exacerbate with this drug, and also the drug itself can lead to first onset type of eczema. Then mostly the latency, like within we start tablet within medication within 7 to 40 days, we can see exacerbation of a pre-existing eczema, or we can see new onset eczemas can develop. Sometimes the patient will say that I had a plaque or a patch in my hand. After taking this tablet, we started having oozing. Oozing is a classical feature in eczema, in acute stage of eczema. So sometimes the patient will say I'll have increased oozing. Yesterday patient came telling me that I took cetirizine. Cetirizine is a very important antihistamine we always give for pruritus, and after taking cetirizine, the patient started oozing from the eczema. So that is also very important. We can't give that class of antihistamine. We have to go for some other class of antihistamine. So this is the common clinical picture of eczema. You can see this is acute eczema. You can see scaling, this crusting and erythema and oozing from the skin. This is a drug-induced eczema. This is a drug-induced eczema due to antihistamine. Then next type is systemic drug associated with the drug-induced eczemas, like beta blockers and any drugs we can lead, antihistamines, even analgesics, NSAIDs, opiates, paracetamol, corticosteroids leads to eczema, and beta blockers, alpha blockers. Methoxysuralin is a very common condition. We dermatologists use this very widely for phototherapy, so it can lead to the topical application, even the systemic application can lead to any type of drug reaction, and mostly the topical the methoxysuralin can lead to eczema. Many antibiotics like amoxicillin, ceftriaxone, chloramphenicol, clindamycin, neomycin, nystatin. This nystatin, neomycin, the topical medications I am telling about, and many antihistamines like cetirizine, diphenhydramine, hydroxyzine, mostly the first generation antihistamines, antihypertensives, and hydrochlorothiazide. Anti-inflammatories like N-acetyl salicylic acid, 5-aminosalicylic acid, corticosteroids, antivirals, biological agents like cetuximab, infliximab, and calcium channel blockers, chemotherapeutic agents like 5-fluorouracil, mitomycin, paclitaxel, vincristine. Anything can lead to eczemas. Clobazam, clonidine, doxepin, ephedrine, glyceryl trinitrate, heparin, even topical application of anything, hydrocarbons, hexamethonium sodium, anything can lead to eczema. Eczema is a very common condition. Most of the patients will tell that existing eczema is increased after taking. The most common scenario is the patient already have an eczema is increased with some class of drugs. And mostly this is also the main management of all the drug reaction is cessation of the causative drug immediately, because most of the drug reaction will subside within the stoppage of the drugs. Mostly we don't need a systemic steroid sometimes. Just with the topical steroid, emollients and antihistamines we can manage majority of benign cutaneous drug reactions. This is a special type of drug reaction, symmetrical drug-related intertriginous and flexural exanthem stripe. This is a new entity. And this is also a benign condition, and it mimics a lot of other skin conditions. The stripe will mimic a lot of other skin conditions, because it's mostly present only in the flexures. It starts in the buttocks and then it will progress, and we can only see this drug reaction only in the flexures. So it can mimic a lot other dermatological conditions. So it's very important for all the patients, we have to take the drug history. So there will be a symmetric involvement of gluteal and intertriginous region, and most of the time it won't be having any systemic involvement. Patient will have intense pruritus. It starts as a premonitory symptom of pruritus, and within 1 or 2 days the evolution of rashes like erythematous and edematous rashes with scaling will start over the flexures. This is a classical picture of stripe. So mostly the very common thing is penicillin. All type of drug reaction, most common thing is penicillins, cephalosporin, clindamycin, erythromycin, NSAIDs, termicin, and hydrochlorothiazide. terbinafine, cimetidine, deflazacort, heparin, valacyclovir, mitomycin. Many drugs are there which can lead to stripe as well. This is also symptomatic treatment, and mostly there won't be any much systemic involvement. So the withdrawal of drug and symptomatic management is enough for this condition as well. And sometimes for this thing we can give a patch test, oral provocation test. So most of the penile drug reactions we can re-challenge the drug. We can give, and re-challenge has different protocols, like starting in a low dose, giving in an alternate day course, or weekly once we can give re-challenge, and we can make the patient sensitized to a drug. If it is a very important drug, we can make the patient sensitized, because as in a case of syphilis, only the drug of only drug we can, as a very effective drug is penicillin, which is a very always there will be a chance of very high drug reaction like anaphylaxis, angioedema, drugs, any Jarisch Hexamer reaction. So in that condition, we have no other choice other than sensitizing penicillins. So we can sensitize drugs while giving a very low dose, and re-challenge with the sensitization is also we can do it most of the benign cutaneous drug reactions. And then drug-induced urticaria, angioedema, and anaphylaxis. And so there will be all the signs of urticaria, angioedema, and anaphylaxis within, usually when in the urticaria, within minutes, hours to 24 hours. Within that period, they will develop, that is the history. Within that period, we will get the urticaria, angioedema after infusing the drug. If you are again infusing the drug, definitely the condition is going to exacerbate, and most of the time the anaphylaxis will get in second time, because later if the medicine is get sensitized, these drug reactions can wane off, and it can lead to mild reaction as well. So usually within 24 to 36 hours of drug ingestion the first occasion, and we have to be very careful in urticaria, angioedema. If we are re-challenging the drugs, most of the times it can lead to very severe reactions like anaphylaxis. And if we are re-challenging the drug, it should be in a very low dose. So if it is in a high dose, it can lead to, especially in the second time, it can lead to anaphylaxis. So this is urticaria. You can see hives and veins. So mostly the history of urticaria will be the spontaneously subsiding lesion within 24 hours. There will be hives, can be erythema, and there will be burning sensation. So drug-specific IG can be done, and skin prick testing, intradermal testing, and challenging tests like oral provocation testing can be done. And the treatment is antihistamines, corticosteroids, and if needed, adrenaline. And drug-induced serum sickness-like reaction. This is entirely different from serum sickness. It's just as a term is because there is a triad of fever, rash, arthralgia, or arthritis. So these are the drugs which leads to serum sickness reaction. Mostly the antibiotics like penicillins, beta-lactams, meropenem, minocycline, griseofulvin, itraconazole, and streptokinase, insulin, biologicals like infliximab, omalizumab, and rituximab. The same thing like withdrawal of the drug and symptomatic management. And like in our drug reaction, this condition is very important, because most of the time if you are saying that this is a drug reaction, the patient will say like, this medicine I'm taking for long, I'm taking for 1 year, I'm taking for 5 years, but at that time I didn't develop any drug reaction, but now I'm getting, why you are saying it is a drug reaction? So this is that condition in which any point of time, like even the drugs may be started a year back, 5 years back, 6 years back, 10 years back, we can have the drug reaction. It's type of like in a drug reaction. Any time, like the patient in the chronic medication, most of the time we are seeing this for antihypertensives and diabetic medications, because the patient will be taking that medication for long, cardiac medication as well. Then suddenly they develop this type of drug reaction, because this mechanism has very different many types of drug mechanisms are there, like inducing autoantibodies. So it takes some time, and also photo-induced, sometimes the intense sun exposure, that also needs a sensitization for having a sun exposure. So at some point of time, this drug will have that immunological variations and mechanisms which can lead to this type of drug reaction. So it is very typical of lichen planus, but mild, like in a clinical point of view, we can say mild differences are there. And if you're seeing a lichenoid type of drug reaction, that violaceous type of drug reactions, we can definitely, if you're taking the clinical history also, we can see even sometimes the patient will present immediately after, like some anti-tubercular ATD drugs, if you are saying very soon also we can see this lichenoid type of drug reactions. So many type of lesions are there in lichenoid drug reactions, like classical SLE type of drug reaction and classical LP type of drug reactions. So this drug-induced lupus, all the signs, all the immunological features, everything will be similar to that of the cutaneous LE, not only cutaneous, even systemic LE, and even the complications will be very similar, and it will be like LE itself, like lupus erythematosus. So this is a lichenoid type of drug reaction. In cutaneous LE type of drug reaction, the clinical lesion will be typical of like LE with the malar rash, with DLE type of lesions, SLE type of lesions, and subcutaneous LE type of lesions, even erythroderma, dress, SJS type of presentation in a cutaneous LE. These are all very common with drug-induced lichenoid reactions. So in lichen planus, mostly like anti-malarials, and these are new medications and even the old medications, everything can lead to this, like beta blockers, AC inhibitors, cardiac drugs, sulfonylureas. And these are the lupus erythematosus, drug-induced LE, the drugs which are causing like AC inhibitors, calcium channel blockers, minocycline, then hydralazine, quinidine, minocycline, cimetidine. These are the drugs which can lead to SLE, cutaneous LE, or systemic lupus erythematosus, which is drug-induced. So in LE type, all the cutaneous LE, all the features of systemic lupus erythematosus will be there in drug-induced, and the complications and comorbidities will be similar to that of LP or LE if you are not treated properly, if you are not identifying the drug. And once we are stopping this type of cutaneous LE, this is a one type of drug reaction which will take a very long time to subside. And the course and prognosis is similar to the LE if you are not stopping the offending drug. So there will be an SLE, there will be anti-Ro antibodies positivity, ANA positivity, anti-histone antibody positivity, and in lichen planus type reactions, there will be lichenoid reactions and spongiosas in the histology. So the management is similar of stopping the drug, and according to the clinical scenario, we can treat it with the systemic or topical steroids and antihistamine. This is a drug reaction called fixed drug eruption. In this condition, there will be always the one drug, if you are taking the second time, it will have a similar type of reaction in the same place. That's why it's called as fixed drug reaction. There will be violaceous, purpuric, can be present as ulcer, can be present as blister. So the initial time there will be one patch of plaque. The second time, if you are taking the same medication at the same area and nearby areas, will get the similar kind of reaction. So even the food can lead to this FTE. Like many, not only the drugs, even preservatives, added foods, colored foods can lead to this FTE. And second thing is pityriasis rosea. It is also condition. Pityriasis rosea is a reactive pattern of viral infection. This is a drug-induced pityriasis rosea. It presents as scaly papules and plaques, and the very typical distribution, like along the skin lines. You can see the skin lines. The very typical Christmas pattern, Christmas tree pattern involvement of the skin will be there, and many drugs as well are leading to pityriasis rosea. And severe cutaneous adverse drug reactions. Mainly the severe cutaneous adverse drug reactions are AGEP, acute generalized exanthematous pustulosis, and DRESS syndrome, drug reaction with eosinophilia and systemic symptoms, drug-induced generalized exfoliative dermatitis, and Stevens-Johnson syndrome, and TN, toxic epidermal necrolysis. In most of these conditions, we cannot re-challenge the drug, and all the conditions will have a systemic involvement, and even the very low dose and very single dose can lead to all this condition, and very low dose can, if we are re-challenging with that drug, we can have a very severe reactions. So AGAP, it is a rapid appearance. It's a very incubation period is very less for this condition, 2 to 5 days. The rapid appearance of sheets of non-follicular, it's a very mimicker of a folliculitis of miliaria or psoriasis. So usually seen starts in flexures, and it's a self-limiting phenomenon if we are stopping the drugs. It is a very mimicker of miliaria pustulosa. So the commonest drugs are quinolones, terbinafine, TSM, penicillins. and we have to stop the drug, and there is a short latency period in AGEP. There will be burning, itching, and there will be many sterile follicular pustules. We can do if you are the gram stain or the pus culture sensitivity, we can do from this, and we can see the inflammatory reactions with the neutrophils, and there will be histopathological changes, fever, increased neutrophil count, and the acute evolution, evolution of this drug reaction. And the main treatment is the withdrawal of the drug and corticosteroids and emollients. This is a DRESS syndrome. DRESS syndrome is with the eosinophilia and systemic symptoms, and it is one of the scar syndrome with cutaneous features, rash, systemic. Mainly, most of the conditions there will be not like most of the conditions. There is systemic involvement only. We can diagnose it as DRESS syndrome. So, it generalized macular any type of drug reaction, like DRESS will present as Stevens-Johnson or TEN. DRESS will present as early-like presentation. DRESS will present as lichen or drug reactions. So, DRESS has very type of clinical presentation, and many drugs leads to this condition like sulfa, furosemide, antibiotics, NSAIDs. And Registrar is a scoring system for this drug. We will see what there is a fever, eosinophilia, systemic involvement. Any system can be involved, like lymphadenopathy, organ involvement like renal, liver, cardiac involvement, lung involvement will be there in DRESS syndrome. So we can make a diagnosis of possible, probable, and definite case according to the clinical condition. And it's a lot of comorbidities are there. The fulminant liver failure is a life-threatening complication of DRESS syndrome. Sometimes liver transplant has to be done for this condition, and mortality is 5 to 10% with them. Mostly the mortality is due to hepatic failure, interstitial nephritis, interstitial pneumonitis, thyroid dysfunction, myocarditis. It can lead to autoimmune phenomena like SLE, autoimmune thyroid disorders, and it can lead to chronic exfoliative dermatitis as well. Treatment is as well this is a drug hypersensitivity reaction. So in DRESS syndrome, we need to prolong treatment with this systemic steroids, like 1 to 3 months of systemic steroid may be needed in the DRESS syndrome, because even after stopping the drug, as it is a hypersensitivity reaction, the systemic involvement and cutaneous involvement will not be subsided, as it is a drug hypersensitive. Immunological reactions are happening in this condition. That is the reason also for this very increased morbidity and clinical picture is varied in this condition. It's because of this hypersensitivity reaction, and so it needs prolonged course of steroid, that also high dose, 1 mg per kg per dose of corticosteroids is needed. Sometimes if it is not subsiding with steroids, we have to give cyclosporin, IVIG, plasmapheresis, cyclophosphamide or rituximab. And secondly, next thing, exfoliative dermatitis, a generalized erythema exfoliation of the skin is called exfoliative dermatitis. This is another severe acute cutaneous drug reaction. Many drugs can lead to this condition as well. This also can have a lot of morbidities and organ involvement, like cardiac involvement, mostly in erythroderma. In a DRESS, we can say it is hepatic involvement, most common we are saying with, but in exfoliated dermatitis, there will be hypothermia, fever, lymphadenopathy, organomegaly, mainly high output cardiac failure, because of the loss of transepidermal elimination of water and hemodynamic changes, which leads to this high output cardiac failure and renal failure and erythroderma. So this is also very important to identify the drug and the need of corticosteroids and the systemic and topical corticosteroids. And next is Stevens-Johnson syndrome and TEN. This is also a very very severe and very high mortality rate is there for Stevens-Johnson syndrome. And in this condition, if it is involving less than 10% of body involvement is there, it is SGS, and if it is more than 10%, 10 to 30% is SGS-TEN overlap, and more than 30% it is TEN. So it is also a very devastating condition and very systemic, so many systemic complications and multi-organ failure are there in SGS as well. And there is a very high mortality, and not only the mortality in this condition, we have a lot of sequelae like scarring in the eyes, corneal scarring, even the skin will have a lot of sequelae in this SGS-TEN type of adverse drug reaction. Commonest drug is allopurinol, carbamazepine, phenobarbital, phenytoin, sulfasalazine. And there is this classification severity, Bastuji-Karin severity classification. which means we can classify this type of drug reaction into SGS if it is less than 10% and TN if it is more than 30%. And there should be more than 2 mucosal involvement to say it as SGS TN. And if there is only one mucosal involvement with this classical type of charring and purpuric rashes in the body with peeling of the skin, it will be, we can classify it into erythema multiforme major or minor. So this erythema multiforme is another type of a drug reaction that it is a subvariant of this SGS-TN. So the mucosal involvement is the only one criteria saying whether it is an HGS or TN according to the Bertuzzi-Garin criteria. So it can involve the mucous membrane, eyes, mouth, nose, genitalia, and this mucosal involvement is an early feature. So this is a generalized SGS-TN patient. It's a generalized peeling, you can say charring of the skin. And there is a scoring system that's called which predict the mortality. So if the scoring system is more than 7, the 98.7% of mortality is seen in SGS-TN. So we have to do a lot of investigation. All the severe drug reactions type, adverse cutaneous severe type of drug reactions, we need to monitor all the organ involvement. We need to see even electrolytes, blood count, amines, bicarbonate, all the basic investigations we need to go through so that we know which all multi-organ involvement is there in type of drug reaction. And the treatment is withdrawal of drug. Basically it is nursing care in this SGS because most of the skin have been peeled. We have to prevent from secondary bacterial infection. In this SGS-TN, we should not give more prolonged, as in Dravet syndrome, we should not give prolonged course of systemic steroids in this condition because it can lead to immunosuppression and mortality. So first line is obviously the corticosteroids, and second line is IVIG. It is also case dependent. If the SGS is presenting within 24 to 78 hours only, we can give IVIG. If it is not responding to corticosteroid, we can give cyclosporin or a pulse dose of methylprednisolone. Thank you.
I am Dr. Vinita from Department of Dermatology. And today I will be talking about the immunobullous disorders and its common mimickers. And it is also a vast topic, but we will make it as brief as possible. And immunobullous disorders are a group of conditions characterized by antibody-mediated autoimmune responses against the structural elements of the skin, resulting in blistering of the skin and mucosa. And this is associated with a significant morbidity and even mortality if left untreated. We have even lost several patients with severe diseases. And to understand the immunobullous disorders, we have to know the basics, just the basic structural elements of the skin. And this is the epidermis, and down the pink color structure is the dermis. Point.
So you can use a cursor.
Cursor is not moving. Okay, got it. And this is the epidermis, and this is the dermis. And we can see these are the basal keratinocytes, and each keratinocyte is joined with one another by a few structural elements called desmosomes. And similarly, the epidermis is connected to the dermis by a few structural elements called hemidesmosomes. And there are multiple components in desmosomes and hemidesmosomes, but of which is very important are the desmoglin 1 and 3 and the bullous pemphigoid BP antigen 180 and 230. And so, based on the structural element involved, the bullous disorders can be classified into intraepidermal and subepidermal disorders. And when the antibody is formed against the structural elements such as desmoglins, which are present inside the epidermis, as we see in the as we discussed in the last slide, and the bulla formation will be inside the epidermis. It is called intraepidermal blisters. At the same time, when the antibody is formed against the hemidesmosomes, which connect the epidermis and the dermis, the bulla will be formed beneath the epidermis. Those are called as subepidermal blisters. The intraepidermal blisters tend to rupture easily, leaving behind erosions, whereas the subepidermal blisters will be very tough to rupture and will be very tense. And these are classification of intraepidermal and subepidermal disorders. Intraepidermal disorders are called as pemphigus group, which contains pemphigus vulgaris, a variant of which is pemphigus vegetans, pemphigus foliaceus, IgA pemphigus, and paraneoplastic pemphigus. And subepidermal disorders are called pemphigoid group, which includes bullous pemphigoid, mucous membrane pemphigoid, pemphigoid gestationis, linear IgA, dermatitis herpetiformis, EVA, and bullous SLE, of which we will be concentrating only about the prototypes, that is pemphigus vulgaris and bullous pemphigoid. And the pemphigus vulgaris, pemphix in Greek means it's blister or bubble, hence the name. and it can occur at any age, but more common in 4th and 6th decades of life. And it has genetic descent also, so it's frequently observed with Jewish and Mediterranean descent. And it's frequently associated with other autoimmune disorders such as thyroid, rheumatoid arthritis, and type 1 diabetes. And few drugs are also are known to cause pemphigus diseases. Most common of which is the penicillamine thiol group, and the non-thiol groups like AC inhibitors and glibenclamide, and the phenol groups such as cephalosporins, rifampicin, phenobarbital, and aspirin can also lead to pemphigus. And the target antigens, as we saw in the previous slides, it is desmoglins 1 and 3. And it is also important to know the location of the desmoglins 1 and 3 because it decides the clinical features. Desmoglin 1 in skin, normally it is present throughout the epidermis, whereas desmoglin 3 is present only in the basal layers. Whereas in mucous membrane, desmoglin 3 predominates than desmoglin 1. So when the antibodies are formed against desmoglin 3, the patient will present predominantly with mucosal erosions with no or limited skin lesions. Whereas when the antibodies are formed against both desmoglin 1 and 3, the patient will present with mucosal erosions as well as deeper skin blisters. So this is a patient in his mid-30s. He presented to us with multiple fluid-filled blisters and large erosions. He also had many crusted plaques, mainly distributed over the trunk as well as face and scalp. And this is a classical presentation of pemphigus vulgaris. And this is patient 2. This patient presented to us only with blisters, only with bullae and vesicles, and of which most of the blisters were tense, but few blisters were flaccid. So in this case, sometimes it's difficult to diagnose between pemphigus and bullous pemphigoid. In such cases, we can do simple clinical tests like Nikolsky's sign. Nikolsky's sign is nothing but a tangential pressure will be applied over the bony prominences and the epidermis will just slide over the dermis. And this is positive in pemphigus. And the other bedside test is the bulla spread sign, where the border of the bulla is marked with a pen, and when the pressure is applied from one end of the bulla will spread beyond the line. This is also a test which is done clinically. Easy to differentiate. Sometimes in older bullous pemphigoid cases, this bulla spread sign can also be positive. And this is case 3. This patient is in her mid-50s. She was admitted in our hospital a few months back. And she presented with predominantly oral lesions. You can see the crusting and the mucosal lesions, and prominent vegetative plaques over the axilla and groin alone. Only these lesions were found, and very few flaccid bullae were found along the lesions, and the rest of the body parts were normal. So, a clinical differential diagnosis of pemphigus vegetans, which is a variant of pemphigus vulgaris, which presents typically like these vegetative plaques over the flexures. So the first diagnosis was pemphigus vegetans, followed by pemphigus vulgaris, and the last one was Haley disease, which is a genetic condition. It is also called as benign familial pemphigus male, but the investigations were in favor of pemphigus vulgaris only. So it can be, the presentation may be varied. And this is a patient which presented only with mucosal lesions, only with oral lesions. So this cutaneous involvement was not there, and the patient had a very ill-defined and erosions over the palate and the buccal mucosa. And this kind of presentation can be isolated mucosal oral pemphigus, or it can be an early manifestation of the cutaneous disease. It can be either. And intact bulla, as we see in the skin, it cannot be seen in the mucous membranes. The other mucous areas affected can be conjunctiva, nasopharynx, larynx, esophagus, urethra, vulva, and cervix. So the other mucosal surfaces can also be involved. And the nails, sometimes patients present with nail changes alone, like paronychia, nail dystrophies, and hemorrhages inside the nail bed. So next we'll move on to bullous pemphigoid, and this is the subepidermal immunobullous disorder, and the two target proteins are BP180 and BP230, as we see in the saw in the picture. And this is a disease of elderly, that is, it mostly affects the elderly patients, mean age between 69 and 83 years, and it is commonly associated with internal malignancies, neurological and psychiatric disorders, commonly associated with Parkinson's and uni and bipolar disorders. And drug-induced BP is an entity which we see commonly nowadays. Most common drugs which are associated with BP are the diuretics, that is furosemide, and DPP-4 inhibitors, which is vildagliptin, and we have seen cases drug-induced BP. Though there are many other drugs which can cause BP. Pathophysiology of BP is very simple. It is following the binding of antibody to the target antigens, the complement is activated, and along with the chemokines and the interleukin 6 and 8, it causes the release of reactive oxygen species, and these reactive oxygen species separates the epidermis from the dermis, causing the bulla formation. So the point to be remembered here is bullous pemphigoid is complement mediated. And moving on to clinical features, bullous pemphigoid, it usually has a prodromal non-bullous phase which lasts for several months or years, and this phase consists of pruritus, which can be mild to intractable without any stimulations. It's very difficult to diagnose at this stage, and mostly patients will be treated as pruritus with antihistamines alone. And further, it is followed by exfoliated papules, eczematous or urticarial lesions, and finally comes the bullous stage. And this is a classical clinical presentation of bullous pemphigoid. Multiple tense blisters present over the trunk and limbs. Mostly it is symmetrical. Bullous pemphigoid lesions will be symmetrical. And this is the next patient with the tense blisters. Sometimes patient also presents with this kind of hemorrhagic blisters. And the classical healing pattern will be seen in subepidermal bullous disorders. Like we can see in the last picture, we can see perifollicular pigmentation. It is classical in subepidermal bullous disorders. Along with sometimes milia formation will also be there. These tiny points can help us in differentiating between the pemphigus and bullous pemphigoid sometimes. And we'll go to the diagnosis along with the routine investigations. These routine investigations are very important because the patients with extensive diseases, they are more prone for secondary infections, fluid and electrolyte imbalance, and serious comorbidities also. So, along with this routine tests, we will move on to the specific tests. And the SAM smear is the initial test which we do because it is a simple bedside test. And how to do is that the roof of the blister is removed, and the fluid inside will be scraped and slide, and it is stained with Giemsa and viewed under the microscope. It's such a simple test, and it helps us in differentiating between the two conditions. And in pemphigus vulgaris, it shows classical acantholytic cells as we see here in the first picture. And these are nothing but rounded keratinocytes with hyperdense nucleus at the center, and the cytoplasm will be condensed at the periphery, showing a perinuclear halo. This is classical of pemphigus vulgaris. In the second picture, we can see multiple acantholytic cells, whereas in bullous pemphigoid, it is subepidermal bullous disorder. So the blister will be found only beneath the epidermis. So it contains only plenty of inflammatory cells such as eosinophils, and there will be no acantholytic cells seen in bullous pemphigoid. The next investigation is biopsy, and the biopsy in pemphigus vulgaris shows the intraepidermal blister. We can see the basal layer here, and the blister is present just above the basal layer, and the floor of the blister contains the row of tombstone appearance, which means that the basal keratinocytes will be attached to the epidermis, with the basement membrane. So it is also a classical feature of pemphigus vulgaris, whereas in bullous pemphigoid, this is the blister, and the blister is present beneath the basement membrane, beneath the basal layer. So here is the basal layer, it will be present beneath. So this, and plenty of inflammatory cells with eosinophils are also present here. The next comes the more specific investigation, DIF, which is direct immunofluorescence. And in pemphigus vulgaris, intercellular IgG and C3 pattern will be seen. So we can see the staining. These are the staining, either IgG or C3. And so we can see the staining around each keratinocyte. So this gives a classical fishnet appearance, which is classical for pemphigus. And here, bullous pemphigoid, we can see a linear IgG and C3 pattern. The next investigation is biochip. It is done only in very few centers. And when it is the diagnosis is not direct with DIF and biopsy, we can move on to the next investigation, which is called as biochip. And it contains 6 substrates, and it is one investigation where we can find whether the antigens involved is hemoglobin or BP antigen. Whichever is involved, we can just find it with one investigation, and the sample here is only blood. No need for invasive testing. And the other investigations which can be done are ELISA, immunoblotting, immunoelectron microscopy, and foam techniques to find the specific subtype of pemphigus, because treatment differs. So sometimes we have to go for specific subtypes. Management. In cases of extensive blisters and erosions, intensive nursing care is mandatory, and the prevention of secondary infections by using saline soaks, Russian permanganate soaks, and topical antibiotics if needed. Liberal use of emollients will prevent from frictional stress. Good oral hygiene is very important in mucosal lesions by using soft brushes, and the treatment of any oral candidiasis if any, and adequate nutrition and fluid electrolyte correction is also very important. And specific treatment includes topical treatments, mainly potent topical steroids, and oral lesions can be treated with triamcinolone acetonide. Severe oral lesions which are not responding to triamcinolone acetonide can also be treated with the soluble betamethasone tablets, cyclosporin, and tacrolimus. And systemic therapy, the first line of therapy is prednisolone, 0.5 to 1 mg per kg per day, or equivalent doses of dexamethasone or methylprednisolone. And the second line treatment includes pulse therapy, either dexamethasone or methylprednisolone separately, or DCP, dexamethasone, cyclophosphamide pulse therapy can also be given. Steroid sparing drugs can be combined with the first line therapy steroids to reduce the side effects of steroids like azathioprine, MMF, methotrexate, and dapsone and doxycycline mainly helps in bullous pemphigoid. And dapsone can be used in all the subtypes which are predominantly neutrophil mediated. It will be very effective. And the third line treatment includes rituximab and immunoglobulins. Omalizumab can be used similarly as in bullous pemphigoid, where the IgE levels are more. It will be very effective in bullous pemphigoid. So, are all the bullous disorders, all the bulla present comes under immunobullous disorders? It's not like that. We have some other lesions or some other conditions which are more common than the immunobullous disorders, and we seeing only the most common disorders here. The first one is bullous diabeticorum, which is very common in diabetic patients. It is commonly called diabetic bulla. It will be sudden and spontaneous, sometimes overnight appearance. More common in the acral sites. Trauma and microangiopathy are the most common etiology noted, and it's associated with peripheral neuropathy. And histology shows subepidermal blisters. Spontaneously, it will heal in 2 to 6 weeks, but symptomatically, we can treat diabetic control and rupture of bulla without damaging the superficial epidermis, and we can treat symptomatically. If in cases of secondary infection, we can also give antibiotics. And next comes the coma blisters in patients with ICU. We commonly see many patients with blisters in ICU. And these are not only in patients with coma, but these can also be seen in prolonged immobilization and neurological diseases. And the most common drugs implicated are barbiturates and opioids, which we commonly give in intensive care units. And it will appear within 48 to 72 hours of loss of consciousness. And the most common sites is the pressure site. Local hypoxia is the most common etiology noted. And the histopathology shows subepidermal and sweat gland necrosis, and this sweat gland necrosis further supports the causage of drugs implicated in this blisters, and frequent postural change will also help us. Next comes the frictional blisters. Frictional blisters is common in the areas of thick stratum cornea, and obviously the reason is repeated friction, and histologically blistering will be seen in the stratum granulosum. The other disorders previously saw it will be subepidermal, but here it is stratum granulosum. And most common DD of this frictional blister is a localized variant of epidermolysis bullosa simplex, and so we have to keep this DD in mind in case of repeated frictional blisters. And this is the most common entity which we see, and particularly in this season, bullous insect bite reaction, more common in children than adults. Patient presents with intensely pruritic erythematous papules or nodules, which further leads to blisters. And in this picture, we can see fizzing lesions. If the lesion is present on one side of the flexure, it is easily present over the other side. These are called as fizzing lesions. And histopathology shows abundant eosinophils. And this blister is called the blister beetle, which causes this is the most common culprit in this season particularly. And it is not due to the bite of this blister actually. These beetles have some fluid inside. There are two types of beetles, pea dress beetle and blister beetle. The pea dress beetle has pedrin and blister beetle has cantharidin, both are vesicant agents. So when our skin comes in contact with this chemical, then it further induces blister formation. This is an infant which we saw in our OPD with insect bite reaction in just one finger, and this picture is post aspiration of the blister with symptomatic treatment like antibiotics, and patient it subsided immediately within 5 days. And the last one is infections. This is also most common. The common infections we see are viral and bacterial. Among viral infections, varicella, followed by herpes zoster, followed by herpes simplex, the most common blistering diseases we see. And it can be easily diagnosed by exam smear because acantholytic cells and multinucleated giant cells will be seen. It is classical of these viral infections, multinucleated giant cells, and it is a bedside procedure, so it helps when diagnostic difficulty is there. We can easily do this procedure to diagnose viral infections. And the next comes bacterial infection, that is bullous impetigo. Sometimes bullous impetigo and bullous pemphigoid, it's very difficult to diagnose sometimes clinically. And in such cases, again, Zang smear helps us. And Zang shows dyscartotic acantholytic cells and neutrophils. And Gram stain of the similar sample shows some coccoid bacteria. Few other bullous disorders are bullous small vessel vasculitis, bullous drug eruptions, bullous mastocytosis, and porphyrias will also present as bullous lesions. And these all leads a proper systemic evaluation. So all the blisters are not immunobullous disorders, and right diagnosis is very mandatory to arrive at a proper treatment.